first speaker is Dr. Debashis, and the topic is Snowball. So let us see what he wants to convey in his deliberation.
Thank you so much, sir. Thank you for the kind introduction. Basically, Snowballs is basically we'd like to convey the intermediate uveitis part in our day-to-day practice. So Snowballs. Basically, Snowballs exudates are exudative materials which break loose from the aggregates and float in the vitreous cavity. And they float as vitreous snowball opacities. Apart from that, we also have snow banking where focal globular yellowish exudates, we can see the coalescing to form the massive plaques over the pars plana. These may circumscribe the whole of the pars plana or the peripheral retina, particularly the inferior portions. You can see these vitreous cells are there, as well as the vitreous strands, as we can see, forming ultimately snow banking, particularly in the inferior periphery, leading to pars planitis or intermediate uveitis, which is associated with the snow banking. Usually these situations are idiopathic. Usually the site of inflammation is the ciliary body, as well as the vitreous, as well as the peripheral retina. If we go back into the history, it has been named differently over the years by different authors. Cyclitis by Fuchs, Skiffens called it as peripheral uveitis, Welch told it as pars planitis. Ultimately, IUSG group termed it as intermediate uveitis. However, the first detailed documentation of pars planitis was done by Charles Skiffens way back. And ultimately what we see as intermediate uveitis is inflammation that predominantly involves the anterior vitreous, the peripheral retina, as in the pars plana of the ciliary body. The pars planitis is a type of intermediate uveitis in which the snowball exudates in the vitreous and the snow banking formation in the peripheral retina. Sometimes there is no association with any of these systemic diseases. If we go into the epidemiology, we have 8 to 22% of all uveitis cases and 16 to 33% of all pediatric uveitic cases, and 80% of these cases are bilateral. Usually the age of presentations of these forms of intermediate uveitis is the third decade of life, and the average age of presentation has been from 23 to 28 years of age group. If we go into the incidence part of it, it is usually 2 per 1 lakh of population as per the previous studies. What is the pathogenesis? The exact cause is yet to be known. However, it is thought to be a cell-mediated immunity with a preponderance of the T helper cells and increased sensitivity to the retinal S antigens. It has been identification, quantification and purification of a 36 kilodalton protein circulating associated with the active pars planitis as noted in one of the research studies. What are the symptoms the patient presents with? Usually the patient presents with floaters, painless blurring of the vision. Occasionally there is a dramatic visual loss when there is a vitreous hemorrhage or a CME or a disc edema. If there is a pain, it is usually associated with secondary glaucoma. What are the signs we look for? In most of the situations, it's a quiet eye. In the later stages of the disease, the patient can develop a band-shaped keratopathy. Most of the situations, there is a mild anterior chamber reaction, and in case of when the etiology is of sarcoid or a TB, we can find mutton fat keratic precipitates in the endothelium. There can develop peripheral anterior synechia and occasionally a posterior synechia when the etiology is a sarcoid or a TB. Secondary glaucoma is one of the consequences of this disease. In the posterior segment, we get the vitreous cells and vitreous strands. We get the snowball opacities as well as snow banking in the later stages of the disease. Sometimes we get a retinal vasculitis, and occasionally in the late stages of the disease, peripheral retinal neovascularization. We can see CME as one of its sequelae. There can be a retinal vasculitis. In the late stage, there can be tractional retinal detachments and a disc edema. These are rare, but ERM sometimes seen in pars planitis. In children, in the intermediate uveitis is severe and the prognosis is poor. Sometimes these children present with band-shaped keratopathy. Pars planitis, however, is a self-limiting entity. The inflammation regresses on healing. The aggregates cicatrize to form a limited membrane which is gray or translucent in color and usually remains undisturbed in the eyes. There may be associated slight atrophy of the pars plana and the choroid in the later stages of the disease. Neovascularization happens when there is the ischemia of the peripheral retina leading to neovascularization at the retina, anterior hyaloid phase and pars plana. It is one of the dreaded complications of intermediate uveitis. If I follow the natural course, 10% of these patients they are self-limiting, 59% smoldering, and 31% keeps recurring during the course of the disease. The usual systemic disease associated with intermediate uveitis are sarcoidosis, tuberculosis, and multiple sclerosis. The differential diagnosis in these situations are Masquerade syndrome, particularly intraocular lymphoma, toxocariasis, Eales disease, and amyloidosis. What workup do we expect in a case of intermediate uveitis? You usually do the complete blood count, particularly the DLC and the ESR. We look for the chest X-ray and HZCT chest to rule out tuberculosis and sarcoidosis, MUN2, serum ACE and lysozyme even for sarcoidosis, and quantiferon TB gold test. The ancillary tests we do are angiography, UBM, and OCT. Usually it shows a petalloid appearance on angiography, particularly when there is a macular edema. UBM in pars planitis we do when the pupil is small due to the posterior synegia, you are not able to see properly, and when the media is hazy due to cataract. Particularly, we need to check this out when the IOP is low. OCT again shows the macular edema. It shows cystoid spaces in the macula and increased macular thickness in the pars planitis situations. Coming over to the treatment, the guidelines are basically you treat the intraocular inflammation, the CME, the cataract, the vitreous opacity RD if there is any, and the vitreous hemorrhage. Most of the cases are mild, however, and responds only to the periocular steroids. If you go by the Kaplan's 4-step approach, we start with posterior subtenon injections. If the patient is not responding, we move over to oral steroids. If still it's further detrimental, then we give immunosuppressive agents, and ultimately for complications we go for indirect laser and vitrectomy. A few words about the posterior subtenons. Usually you use triamcinolone acetonide posterior subtenons, and we can repeat this every month. Usually 2 to 3 injections will be sufficient for any such cases. For the oral steroids, only it is indicated in severe bilateral cases and where the failed periocular injections doesn't give me any result. Usual dosage is 1 mg per kg of body weight, tapering 10 mg every week. You can use a low dose steroid if there is a protracted course and it needs to be continued over a prolonged period. When do we use immunosuppressive agents? It is during refractory cases which are not responding to steroids, and we use azathioprine 50 mg 3 times a day or cyclosporin 5 mg per kg. However, mycophenolate mofetil is a very safe drug and can be given 500 mg in a divided dosage. There had been studies which shows the efficacy and safety of mycophenolate mofetil in the treatment of recalcitrant intermediate uveitis, proving the same. When do we do cryotherapy? When the intermediate uveitis is not responding to the oral steroids, the neovascularization has happened in the vitreous base, and we usually use a double freeze and thaw technique in these situations. The latest armamentarium is the Ozurdex implant. The implant is placed in the vitreous cavity of the eye with a single-use applicator in a sutureless office-based procedure. It can be done. And such studies are there in the IJO 2015 journal, Efficacy of Ozurdex Implant in the Treatment of Non-Infectious Intermediate Uveitis, which concludes that Ozurdex implant is a promising treatment option and efficient in controlling the inflammation and CME in cases of non-infectious intermediate uveitis not responding to the standard treatment. This is one of the implants in the vitreous cavity. And when do you do a vitreoretinal surgery? When it's an intractable vitreous inflammation, vitreous opacities and membrane obscuring the vision, unresolving vitreous hemorrhage, retinal detachment, and persistent CME in spite of treatment. There have been studies, pars plana vitrectomy versus immunomodulatory therapy for intermediate uveitis, which confirms that 82% showed resolution of the inflammation. However, 57% had persistent inflammation when even with immunomodulators you can go in for a vitrectomy. When do we go for a cataract operation in these cases? We wait for the burnt out stage to come, not in the active stages of the disease, usually 3 to 6 months when the eye is quiet. Preoperatively, topical systemic and pediocular steroids to be given to avoid further inflammation post-operative phase. Foldable IOLs are recommended and may need to combine with pars plana vitrectomy if there are vitreous membranes and opacities. The evaluation of cataract surgery in intermediate uveitis has been done by Rajesh Fogla et al., which shows vision improved in 94% of the eyes and 71% had visual acuity better than or equal to 618. To conclude, intermediate uveitis is a very puzzling disease. It is not an uncommon condition, and it is a challenge to us, the ophthalmologists. A meticulous examination of the pars plana and early diagnosis and proper management is the aim of this study. Thank you.
Thank you, Dr. Debashis. How long you put the patient on steroids post-operatively?
Post-operatively means after vitrectomy or after cataract surgery. See, if the eye is quiet, the normal steroid course we follow for the cataract surgery is that much is given. And if the eye is not quiet, we again revert back to whatever dosage we are given for the intermediate uveitis. It can be oral steroids if there is an inflammation. If there is no inflammation, we do not give steroids. It's actually we follow the protocol of if there is an inflammation again post surgery, we have to treat it again as an intermediate uveitis de novo, start all afresh.
Almost similar protocol for the patients whom you give subtenance like
usually we give pre-operatively steroids subtenance before 3 days before the cataract surgery, such that there is no recurrence of inflammation post surgery. That is the crux of the story.
Thank you, thank you,
thank you so much. Yes, sir. In smoldering cases, usually we keep a very low dose of steroids, and that keeps the patient's eyes very quiet. And sometimes methotrexate and group of drugs helps in these cases, because we can keep the steroid level low if we give an antimetabolite like methotrexate on a lower dose. It can be given over a period of 6 months, 9 months, even a year. It doesn't cause any side effect. 7.5 milligram per week every Sunday, and throughout week we give the folic acid.
Thank you, Dr. Debashis.